Today we're going to be discussing Chapter 10 in your textbook on personality disorders. Now when we look at personality disorders, there's several clinical features that they have in common. We usually see chronic interpersonal difficulties, and we see problems with identity or the person's sense of self. Some of the clinical features of personality disorders, and also we're going to be referring to the DSM criteria, are pervasive and inflexible, stable and of long duration, clinically significant distress or impairment in functioning, and manifested in at least two areas of their life. So if somebody is having a bad day or somebody shows some symptoms for just a short time but it doesn't continue, then it may not fall under a personality disorder. Now, I want you to really pay attention when you study and kind of get these straight in your head. We have three different clusters of personality disorders. We've got cluster A, which includes paranoid, schizoid, and schizotypal. We've got cluster B, which includes histrionic, narcissistic, antisocial, and borderline. And cluster C, which includes avoidant, dependent, and obsessive compulsive. And you will need to know which cluster each one falls under for your exam. Now, there's a lot of difficulty when we try to do research on personality disorders. There's trouble diagnosing because many times these are comorbid diagnosis. There may be other things going on, and it's hard to kind of untangle that and sort out what exactly is going on with the person. And then studying the causes, because usually we don't see it coming on. And then once the person has been diagnosed with a personality disorder, we're asking them to go back and tell us how things were before, or asking parents or relatives to go back. And so we haven't been able to do a lot of studying before a person exhibits all the symptoms or has a diagnosis. Like I said, there's difficulties in diagnosing the personality disorders. One, the diagnostic criteria is not sharply defined. Like I said, usually we see several disorders occurring at the same time, and so it's hard to know what came first or what caused what, and therefore the diagnostic categories are not mutually exclusive. Cluster A, Cluster B, and Cluster C may have some similarities. And then the dimensional personality characteristics, each person and what they bring, heredity, environment, and those types of things in the way that the disorder manifests itself. Personality disorders may represent extreme levels of normal personality traits. For example, the histrionic personality is just like an outgoing, extrovert, dramatic person on steroids, or the dependent personality is a very agreeable person. The obsessive-compulsive person may be considered a very conscientious person. So some of the personality traits are positive, but when there's extremes, then it moves into being a personality disorder. As I was mentioning earlier, some of the difficulties we have in studying the causes of personality disorders is because of the limited research on the causal factors, and it just began appearing in the DSM-3 in the 1980s, and so it's a relatively new area of study. People with personality disorders are not necessarily open to being studied, and so, as we said, it's a lot of retrospective approaches, looking back at how things were, how did you do this at the time, recalling prior events. And so most of the research is being conducted on people who already have the disorder. Let's look at cluster A personality disorders. As I said, we've got paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. So be sure that you don't get those confused. And they are not schizophrenia, even though we have the schizo there at the beginning. When we talk about paranoid personality disorder, the characteristics of this disorder include suspiciousness and mistrust of others, a tendency to see themselves as blameless, and they're on guard for perceived attacks by others. And so instead of blaming themselves or taking any blame for things, they blame others for their own mistakes and their failures, and may even ascribe evil motives to the other person. And people with paranoid personalities, they're not usually psychotic. Most of the time they're in contact with reality, and they just have that paranoia, and they appear to be at an elevated chance of developing schizophrenia down the road. Schizoid personality disorder. Individuals with schizoid personality disorder are usually unable to form social relationships, but they don't really have an interest in doing that, okay? They may be more introverted, a loner, and they don't have very many close friends or people that they can, talk to. And so people see them as cold and distant and just, a little bit odd. Like I said, this lack of desire to form attachments to others could lead them to be classified as loners or introverts. Now, I don't want to say that all loners or introverts have schizoid personality disorder, but people with schizoid personality disorder tend to be loners and introverts, and they don't really enjoy very much. They don't usually get married. They're not very emotionally reactive. They don't have really positive or negative emotions. They're just kind of apathetic, a little bit aloof, and those types of things. Then we have schizotypal personality disorder. Now, these people also have, an introverted personality. They have pervasive social and interpersonal deficits. But in addition to this, they have some peculiar thought patterns, and they've got some oddities and kind of a little eccentric in their communication and their behavior. So the way they perceive things is skewed and a little odd, and so that interferes with their communication and their social interaction. Now remember, if we go back, the schizoid personality disorder really didn't have a desire to form attachment, but the schizotypal has oddities that make it really hard for them to form those attachments. Next, we have cluster B personality disorders. There's 4 that fall under cluster B: histrionic personality disorder, narcissistic personality disorder, antisocial personality disorder, and borderline personality disorder. Histrionic personality disorder is characterized by excessive attention-seeking behavior and emotionality. And when you look at the DSM-5 criteria, you see that it says a pervasive pattern of excessive emotionality and attention seeking, which begins by early adulthood and presents in a variety of contexts. And then we're looking for 5 or more of the following characteristics. They're uncomfortable in situations where they're not the center of attention. Their interaction with others is often characterized by inappropriate, sexually seductive, or provocative behavior. They display rapidly shifting and shallow expression of emotions, consistently uses physical appearance to draw attention to self, has a style of speech that is excessively impressionistic and lacking in detail, shows self-dramatization, theatrics, and exaggerated expression of emotion, is very suggestible and easily influenced by others, and considers relationships to be more intimate than they actually are. So we're looking at for 5 or more of those characteristics for a diagnosis of histrionic personality disorder. So you'll see they've got this over concern with attractiveness, and they become irritable or have temper outbursts if their attention seeking behavior is frustrated. Then we have narcissistic personality disorder. Individuals with narcissistic personality disorder show an exaggerated sense of self importance, a preoccupation with being admired, and a lack of empathy for the feelings of others. And I haven't mentioned it on all of them, but for narcissistic behavior, we see that more in males than in females. And interesting enough, in the histrionic personality disorder, we see it about equally showing up in males and females. But someone with a narcissistic personality disorder is very self-promoting and unable to really show empathy for someone else. Then we have antisocial personality disorder. Individuals with antisocial personality disorder continually violate and show disregard for the rights of others, either through deceitful, aggressive, or antisocial behavior. And what is characteristic of this is that they typically don't show remorse or show loyalty to anyone. They tend to be impulsive, irritable, and aggressive, and they show a pattern of irresponsible behavior. Now, when we're making this diagnosis, something that's important to remember is that this behavior must have been occurring since the age of 15. And then before age 15, this person must have had symptoms of conduct disorder, which is very similar to antisocial, but if they're 15 and below, we label it more as a conduct disorder. So we're looking for people that just have not developed morally and ethically. They don't follow the approved models of behavior. They may show deceitfulness, shameless manipulation of others, and then, as I mentioned, the history of conduct problems as a child. Borderline personality disorder. This is a very, I guess, a common disorder, or it's one that I've seen a lot as people have come to counseling. It shows up about equally in females and males. My own experience has been that I've seen it more in females, but it is characterized by impulsiveness, inappropriate anger, drastic mood shifts, chronic feelings of boredom, and attempts at self-mutilation or suicide. And one thing that will help if you're trying to recognize borderline personality disorder is to keep in mind that their behavior is an effort to avoid real or imagined abandonment. Okay, if you think about some of the books on borderline disorder, there's one called I Hate You, Please Don't Leave Me. It's the idea of whether you really are planning on abandoning me or ending the relationship or whatever. If I fear that you are, then I may end it before you do, or I may hurt you before you hurt me, or break up with you before you break up with me, and those types of things. Another book for those that live with someone with borderline is called Stop Walking on Eggshells, and that's also a good way to recognize if maybe you're dealing with someone with borderline because you feel like you walk on eggshells around them because you never know what you're going to get. Moving on to cluster C personality disorders. The 3 personality disorders we see here, and they all are equal in males and females except for the obsessive compulsive. We see that higher in males, but they are the avoidant personality disorder, the dependent personality disorder, and the obsessive compulsive personality disorder. Now, when we look at avoidant personality disorder, this person has a hypersensitivity to rejection or anything that would make them feel like they didn't fit in. They may tend to already be shy or have a more introverted personality, and they show an insecurity in social interaction and in initiating relationships. And so in this person, we're looking for a pervasive pattern of social inhibition, feelings of inadequacy and hypersensitivity to negative evaluation, and this usually begins by early adulthood. On the dependent personality disorder, these people tend to show an extreme need to be taken care of, which leads them to be very clingy and be very submissive. They show a lot of fear at the possibility of separation, and sometimes simply having to be alone makes them feel like something's wrong with them or they're inept. And these individuals usually build their lives around other people, kind of push their own needs to the back burner, and really tries to please the people around them to stay involved with them. They may be indiscriminate in their selection of mates, and they may put up with a lot because they'd rather do that than be alone. So this can lead to some abuse situations. You can imagine that a narcissistic personality disorder may be attracted to a dependent personality or vice versa. And these people are also tend to be very indecisive. Obsessive compulsive personality disorder. As we've mentioned on several of the different diagnoses throughout this class, so many things that people may joke about, or oh, I just have to keep my closet organized, I'm so OCD. When you really see what goes into the personality disorder, you realize that it's a lot more than just liking all your clothes facing the same way in the closet or something. Someone with obsessive compulsive personality disorder has an excessive concern with order, rules, and trivial details. They are very preoccupied with these things, and they will try to keep mental and personal control at the expense of flexibility and openness and efficiency. We usually see this beginning by early adulthood, and this may be the person that we look at as a perfectionist and somebody who maybe can never get a project finished because their own standards are so high and they can't meet those. They're very devoted to work and productivity, and have difficulty relaxing and having fun. And so one other thing that we see is that they're unable to discard worn out or worthless objects, and they may be very miserly in their spending style because they want to hoard their money for the future, and they're very rigid and stubborn, which leads to a lack of expressiveness and warmth. Now, this is not to be confused with obsessive compulsive disorder, which we've talked about earlier in the semester. This is obsessive compulsive personality disorder. What are the treatments and outcomes for personality disorders? As you can imagine, there's a lot of difficulties in this. First, there's the treatment difficulties, again, because many people have a comorbid diagnosis or a dual diagnosis, and so it's hard to kind of weed out, which disorder we need to treat first and which came, first. May have different goals than the client has. The clients may be resistant to change because remember, a lot of these personality disorders, well, all of them, serve a purpose or feel an anxiety or a need, and so they may be resistance to change. And because these are personality disorders that interfere with relationships, and relationships being a big part of therapy, there's a lot of challenges there in forming those relationships. So, how do we adapt therapeutic techniques to specific personality disorders? The therapist needs to be familiar with the disorder and be willing to adapt their therapeutic techniques to keep the client engaged. The setting is very important. A lot of these people may end up in a treatment center. Um, with the antisocial, they may end up in prison and things. And so it's been shown that a setting where the therapist can be with the client and make sure that the client comes back to counseling and different things could be very important. And then cognitive therapy has been shown to be one of the most effective treatments with these types of clients. However, as time has gone on, they've realized that people may be better while they're in treatment or while they're incarcerated or while they're in a treatment center, but those changes don't necessarily transfer to the outside world. And so some people have suggested that we may just the best we can do is to manage the disorders, and we may not ever truly be able to overcome them. Treating borderline personality disorder. Borderline personality disorder is best treated with antidepressant medications, again going back to the SSRIs, the selective serotonin reuptake inhibitors, and then also dialectical behavior therapy. This is a fairly newer therapy, and it's a unique kind of cognitive and behavioral therapy that was developed specifically for borderline personality disorder. And the idea is that borderline personality disorder develops because the person is unable to tolerate strong states of negative affect. And so, what they do in dialectical behavior therapy, or DBT, is to encourage patients to accept the negative feelings without engaging in self destructive or other maladaptive behavior. And so they use individual therapy and group therapy. It could also be done over the phone. And it seems to be, pretty successful in treating borderline personality disorder. Antisocial personality disorder and psychopathy. If you remember the diagnostic criteria, this is for a person 18 years and over, and at least 3 of the behavioral problems occurred after age 15, and at least 3 instances of deviant behavior before age 15. And that was, the conduct disorder and things. What are we looking at when we look at someone with antisocial personality disorder? Basically, there's been an inadequate conscience development, and combine that with irresponsible and impulsive behavior, and they may be very charming and have the ability to impress and exploit others, and it's kind of the perfect storm to set up for someone who would lie, steal, cheat, and exhibit other antisocial personality traits. Causal factors that have been identified include genetic influences, low levels of fear or poor conditioning of fear, more general emotional deficits, early parental loss, parental rejection, or inconsistent discipline. So let's look at, if you remember early on when we talked about the diathesis stress model, that some people were born with a predisposition towards something, and then events in their life or the environment that they lived in, kind of the nature versus nurture argument, led to this. So if we look here and we look at the things involved in the parent's life, the employment, their education, stress events, maybe there was divorce or a lot of moving, the neighborhood that the kids live in, the school that they attend, and then when the parents have stressful events, that may lead to ineffective parenting, especially discipline and supervision. So then we've got children that are developing antisocial behavior. Couple it with maybe the neighborhood or the school where they live, and they've got deviant peers, and so they get into some trouble there, leads to early arrest and chronic delinquency, and eventually to an antisocial lifestyle. So this is in no means the way it has to go, but these are a lot of the context in which the antisocial behavior can develop. Treatments and outcomes, as I said, cognitive behavioral treatment offers some promise, and we see it being more successful while the person is still in an inpatient treatment or in prison. But once they get out, it is very difficult for them to maintain the new way of thinking and the new behaviors when they're back out into the real world. And so some of the focus has changed more to management of the behavior than actually treating it.